So now you've just done the best assessment that you can do to determine depression, because we don't have a blood test. What I want you to do now is count up your checks. And you need to make sure they're documented. When you count up checks, if you have 5 or more, it's probably a patient who's got major depressive disorder. If you have 2 to 4, well, let me stop on this. So 5 or more, major depressive disorder must be part of your differential. Look at this question. What medication class is considered first line in a patient who has major depressive disorder? Here's what you need to remember. If you got 5 or more checks, you need to move on these people pretty quickly. We want to give them a medication that stimulates more than one of those neurotransmitters. We typically give them something that stimulates not just serotonin. They need more help than that. We give something that stimulates serotonin and norepinephrine, an SNRI, selective serotonin norepinephrine reuptake inhibitor. Circle number 4, and I got to get some examples from you. Like, what drug are we talking about? What about Pristiq, Effexor, Cymbalta? So when you can stimulate or cause 2 of these neurochemicals, neurotransmitters to rise, we typically see a little bit better results in someone with major depressive disorder. All right? And that was 5 or more checks. For most of us, Pristiq, Effexor, generic. Cymbalta, generic. Okay, so there we go. Those are 3, but 2 is what I asked you to give me, and you'll be good on that. Most of the patients that you will see in primary care are going to have mild to moderate depressive disorder. That means you have 2 to 4 checks. And that's pretty easy to get in patients who have depression. So what does that mean, mild to moderate depressive disorder? It means they don't want to kill themselves or anybody else. They're probably suitable to treat as an outpatient because their judgment is intact. We see loads and loads of these patients in primary care. So how do we get them better? Fortunately, we have a number of ways. When we're involved, we typically are the people who sign a prescription for medication. Psychotherapy works very well, but the very best outcomes occur with both of them in place. You'll have to talk to your patient, because some patients will tell you, I'm not taking a medication. And other patients will tell you, can't you give me a pill? I don't have time to go to a counselor or psychotherapy. So you got to talk to the patient to find out what they are willing to do. Look at this next patient. What medication class is considered first line in a young or middle adult who has mild to moderate depressive disorder? It's always a what? An SSRI, exactly. So statistically, if you make more serotonin available in the brain, you will help more people than if you stimulate one of those other neurotransmitters. You got it? So an SSRI, number 3, is your best answer. Look at the names of some of these SSRIs, and I'll tell you that not only is it less expensive to treat depression now because so many of these are generic, but several of them are on the $4 list. So they all have little different characteristics. They all behave a little bit differently. But to be honest with you, they all make more serotonin available. So let me ask you this. If I came to see you or I'm on a break, I said, man, I got a terrible headache. You got a couple of Tylenol? My expectation would be that in 45 minutes after taking your Tylenol, ibuprofen, my headache would be better. But when a patient comes to see you with depression, you've got to give them an expectation of when they're expected to feel better. Because not a lot of people are going to take something day after day after day for 4 weeks if they haven't seen an improvement in their symptoms. So you have to give them that expectation when you treat them. What's your expectation? Here it is. I want you to take my medication every day. And I think that in 2 to 4 weeks, we'll see some improvement. And you usually remind your patient, the people around you will notice it before you do. All right? The people around you will notice your improvement before you do. But 2 to 4 weeks is the expectation you need to put in their brain. When should they see relief of symptoms? Look, 6 to 12 weeks. You know how long that is? Up to 3 months. You've got to put that expectation in your patients when you give them those medications. Look at your next patient. Which statement is true regarding symptoms of depression in adolescence? And look, this is a select all that apply. What do you know about adolescents with depression? Well, look at number one. Their symptoms may be similar to those of adults, and that's absolutely true depending on the age of where they are in adolescence. A 17-year-old is going to look a lot like an adult. A 12-year-old, a 13-year-old, maybe not. Circle number one. Impulsivity is a common finding. Oh, man, it is. And you know what else? That creates a huge safety risk in an adolescent. Circle number two. Depressed mood as usual. That's the most common symptom, so circle number three. This is also a time when they begin to abuse substances, which for you means you've got to have a way to check and screen for substances. You got to have a urine drug screen company. You got to have some way to screen it, because you can't rely on an answer that an adolescent gives you about a yes I am or no I'm not. Circle number four. Look at number five. Sure, difficulty thinking and concentrating. What happens to their grades in school? Goes way down. Circle that one. The last two are probably not correct. Sorry. Indecisiveness may be present. That's correct, right? Circle number 6. Indecisiveness. But number 7 is the one that is not true. This number 7 says hopelessness would be unusual. No, hopelessness is usual in adolescence. So I want you to circle 1, 2, 3, 4, 5, and 6. It is not number 7, all right? So what I'm trying to convey to you is that the symptoms of depression in adolescents can look a lot like a lot of adults, all right? You've got to be in tune to the symptoms. Look at your next patient. An 85-year-old patient has been diagnosed with moderate depression. What medication class is considered first line? Well, older adults metabolize drugs a whole lot differently and a whole lot less efficiently than any one of us. First-line medication in an older adult is a what? It's an SSRI. Number 3. Circle it. So let's talk a little bit about older adults and depression. The term that you'll see scattered throughout the literature is late life depression, all right, which means it arrives later in life. And so look at these expectations. When do we expect an older adult to get better once you initiate a med? You remember what it was in one of us, a young or middle adult? 2 to 4 weeks. Look at what it is in older adults. 4 to 6 weeks. Look at when you might see resolution of symptoms. 12 to 16 weeks. Do you get why you have to be so patient when you treat depression in older adults? You got it? It's just a whole lot slower process. And they metabolize drugs a whole lot less efficiently. What else do we worry about with older adults in depression? Man, they can have a lot of side effects, even with our safest drug class, which is an SSRI. Some of them begin to exhibit symptoms of Parkinsonism. Some of them develop arrhythmias. Sometimes we see hyponatremia that produces what common neurologic finding? Changes cognitively, right? If they're on a drug like aspirin or an anticoagulant and you toss in an SSRI, their risk of a bleed goes way up. So giving an SSRI to an older adult means you have to watch these people way more closely. So SSRIs are first line, and they're probably safe line for the same reason they're considered first line, rather, in younger adults. It's because they tend to be way, way safer. And I'll tell you why in just a second. But I need to make sure that you know what the Beers list is. Do you have it? Some people have an app for their phone. If you're in an adult or an adult gero program, you better darn well know what that is. Family people, you got to know. The Beers list was developed decades ago by a Dr. Beers, and he was very, very concerned about making sure that older adults weren't exposed to inappropriate medications, especially the anticholinergic side effects. So the famous Beers list was developed. And it gave us good choices of medications to make for patients who had certain conditions, especially if they were older. So the Beers list really should guide your geriatric prescribing. As you probably know, the Beers list was updated about a year ago. And not only did it tell us what drugs to stay away from, like don't give an older adult a TCA, but it gave us choices for our drugs to use in our older patients. So the Beers list is a big deal. It should help guide your geriatric prescribing. What else do you need to know about older adults? Well, we see a lot of depression in late life. We also know that with regard to suicide rates, twice as high in older patients, especially in males, especially if there's a gun in the house. So you have to know your patient. You got to know what their support system is, and you got to know what may be in their house that will increase the risk if they've got depression. So look at your patient. She's a 75-year-old female who was diagnosed with depression and started on sertraline. What drug is that? Zoloft. If they ask you on the exam to give a certain dosage of a medication, they're going to tell you what the usual range is. So the usual range for Zoloft is 50 to 200. The question is, what dosage would be a good starting dose in this patient? Well, she's 75. What are you thinking? A good rule of thumb is half of the lowest dose. All right, so 25 milligrams, very, very good choice. Once daily. How about number 1? TCA, I used that acronym before. Obviously, that's tricyclic antidepressants. Those are some of the first ones to come out. And actually, they're making a big comeback. We're seeing loads of TCAs being used now, or at least way more than we did in the last 10 years. TCA use for treatment of depression has declined drastically in the past 12 to 15 years, such that SSRIs are way more commonly prescribed. Why is this? It's not because of efficacy, because the TCAs are as efficacious as the SSRIs. It is absolutely safety. Here's what I'm talking about. If you work in the ER, you know this. If a patient who is depressed becomes suicidal, and you've got them on amitriptyline, and they swallow their whole bottle of amitriptyline, game over. If they're depressed and they become suicidal and they swallow their 30 days of Lexapro, they're going to vomit their toes up. But they'll live to tell about it the next day. So with TCAs and SSRIs, the reason the big shift was made was for safety purposes. Because you know that as you treat a patient for depression, as they begin to feel better and have more energy, their risk of suicide does what? It goes up. You always have to watch them, especially in adolescence. So safety is the big reason. Which brings us to this, and I think really it's shocking. The 7th leading cause of death in the United States is suicide. The 7th leading cause of death. Consequently, when patients come in to see you, they only came because they want your help. And to be honest, ethically and morally, I feel like I have to do everything I can to help them, and you should too. So what will you do? You got to know the questions to ask. And so here you go. The first question you ask is, are you thinking of hurting yourself? What you're trying to establish is whether or not there's suicidal ideation in this patient. That's why you're doing it. And if it's a yes, you got to ask them how long. If somebody says, I've been thinking about killing myself for 5 years. Well, maybe they have ADD too. I don't know what, but it's scary to me, but it's not as scary as somebody who says, about a week. And when somebody looks at you like that and says it in that way, if your heartbeat doesn't quicken, I don't know why. Or are you thinking about hurting yourself? If they say yes, you got to ask the next question. The next question is, what are you thinking about doing? I don't really know what I would do. I just wish I wasn't here. I'm not as worried about that patient as someone who says, I'm going to shoot myself. If somebody says, I'm going to shoot myself, you got to ask the third question. Do you have a gun with bullets? So every time they say yes, the risk rises and rises and rises. And to be honest with you, this is not a 10-minute sore throat visit. The hardest part of your day might be to find somebody to call for this patient. especially if you feel like this is someone who could be treated as an outpatient. So what do? With regard to suicide, this is what we're looking at. There's imminent risk. Imminent risk means I got to find something to do with this patient right now. I can't let him out of my sight, or I got to get a nurse in here to keep their eyes on this patient so I can leave. Or there's elevated risk but not imminent. The majority of patients come in and are like that. And I'll be honest with you, this is going to be a judgment call for you. And it's never one that you can be 100% confident in making, especially on a Friday. No, I really mean it. On a Friday is a day in which So this is what you've got to think about, because it's going to determine what your next action is. And I don't know where you're going to land, but wherever it is you land, you've got to know your community resources. Who are you going to call? When you've got someone who's got an elevated risk but not imminent, who are you going to call and how are you going to manage them? If it's somebody who's got an imminent risk, you need to know where you send them if they have no money. Where do you send them if they're an adolescent? Where do you send them if they're a medically fragile older adult? So you got to know your community resources, and I can't tell you how important it is for you to know those. So what's your goal? You know what I tell the students I precept? Listen, on your way home this afternoon after this clinical, if you see an old scraggly, hurt, sick dog on the side of the road, you can pull your car over, pick him up, bring him home, and nurse him back to health. But you're going to see a lot of patients who come through this clinic just like that, and you can't take them home with you. What are you going to do with that patient? So you got to keep these patients safe until you can get them to another level of care, all right? Or somebody who can assume responsibility for them. I'm changing gears. Let's talk about bipolar disorder. And bipolar disorder is really an interesting thing. It's interesting in that we have patients who have unipolar depression, which we've just talked about. But when patients have bipolar disorder, they go between depression and either hypomania or mania. All right? So here's a fine point I want to make sure you don't forget it in case you see it again. If someone is diagnosed with bipolar disorder, it always means that they have had either a manic or a hypomanic episode. You got it? You only are diagnosed with bipolar disorder if you've had a manic or a hypomanic episode. There are two types of bipolar disorder. There's bipolar 1, where people have mania, and it swings between mania one pole and depression on the other. That one's not the most common. The most common is bipolar 2. It is way more prevalent. These are people who've had at least one hypomanic episode, or maybe they just kind of exist in that area, but they've also swung over to the depressed side. You will see way more of those patients, certainly, than the bipolar ones.